So real quick, let's finish out our last topic within glomerulonephritis, which is infection-associated glomerulonephritis. And within children, there's the standard um, model of infection-associated glomerulonephritis that is post-streptococcal GN. And this is certainly a common manifestation of this phenomenon within the pediatric population. But it's important to recognize that in adult infection-associated glomerulonephritis, there is a different flavor to it. In most cases, this is not from a streptococcal infection, but rather staphylococcal infections in published case series are the most common causal agents. And it's often in a diabetic patient with like diabetic foot infection. But there is other potential infectious agents that are also associated with infection-associated GN. And then to make things a little bit more complicated still, many or a significant proportion of patients with what is presumed to be infection-associated glomerulonephritis do not even have an identified preceding or concomitant infection. And so the presumption in that case is that this was like a folliculitis that went unnoticed and then precipitated this systemic reaction that we recognize later. So again, adult onset infection-associated glomerulonephritis has greater variability in its presentation. Don't forget, staphylococcal infections are the most common causal agents in adults. And how do these present? Well, typically with a nephritic syndrome. However, you can have more subtle presentations where just a little bit of proteinuria is present, or a more nephrotic picture. So again, a varied presentation in this glomerular disease. In the classic pediatric post-streptococcal GN, there's typically a latency of around 1 to 6 weeks after the pharyngitis or skin infection, cellulitis, that you develop this renal response or renal disease. In the adult onset infection-associated GN, there is a more coincident presentation, that is, the infection and GN are recognized simultaneously. Of course, some of these infections can be chronic in nature, such as osteomyelitis, so there could have been a latency that was just not recognized. Now, what are some of the non-invasive patterns in complement and serologies that you can use to narrow down the differential diagnosis to this subset of likely GNs? Well, there's a greater usefulness or reliability of these non-invasive markers in the classic pediatric post-streptococcal GN. C3 is fairly consistently depressed in this infection-associated GN, and it's usually with a normal C4, and that typically recovers within about 2 months. In some cases, this is used, as I understand it, to take a more conservative approach in pediatric patients, where a pediatric patient may present with hematuria and proteinuria and a presumed preceding infection. They may have the depressed complements, and then one sometimes will wait for a few months to see whether things get better before looking at alternatives such as C3GN in a pediatric patient. So again, sometimes this typical timeline of C3 evolution, depression followed by recovery within 8 weeks, is utilized to take a more conservative approach before committing to kidney biopsy in a patient. Streptozyme antibody panel is basically a as the name implies, a panel of several different antibodies looking for antibodies to the streptococcal infection, for instance, streptolysin or others within that panel. That is positive in the predominance of patients. There is greater sensitivity of this test when you have pharyngitis as opposed to the erysipelas or cellulitis. For adult onset infection-associated GN, you can see that the depressed complement is less reliable, less consistent. You can have C4 that's depressed more consistently than in the pediatric post-streptococcal GN. And there may be a greater likelihood of developing these depressed complements when the infection is more chronic. Renal biopsy classically shows plenty of neutrophils. So here we have a segmented nucleus in some of these infiltrating cells. Here's another one. Here's another one. So those would be more consistent with an infection-associated GN. Sometimes it is hard to discriminate between a C3 GN and infection-associated GN. Because, as we'll talk about, immunofluorescence can sometimes have only C3 present or C3 dominance, even in infection-associated GN. When I see more neutrophilic infiltrate, and I combine that with some large subepithelial deposits, then I am more leaning towards infection-associated GN. However, these are not diagnostic. You put together a full package and then make a best judgment that you're dealing with infection-associated GN as opposed to other possibilities. When there's neutrophilic infiltrate, an adjective for that finding would be exudative proliferative glomerulonephritis. So the term exudative refers to the presence of neutrophils. And then sometimes you can have an MPGN pattern, especially when you're dealing with chronic infections. Let me restate that MPGN is not a diagnosis, it's a pattern. There's multiple different conditions that can manifest with that MPGN pattern. That is double contours, increase in mesangial cellularity, as well as matrix, as well as endocapillary proliferation. So again, infection-associated GN can do the same. Shunt nephritis is a classic or sort of a historic condition that is associated that was described in the literature in patients with VP shunts that become chronically infected. Okay, that's one example, but one could presume a MPGN, more likely to see an MPGN pattern with subacute bacterial endocarditis or osteomyelitis. In immunofluorescence patterns, remember, I'm typically going to see C3 that's present, dominant or co-dominant with other immunoglobulins present. So how do you discriminate this from C3 glomerulopathies? Well, remember, this is a subjective judgment by a pathologist. If you see C3 in intensity, in 2 degrees more intensity than the other immunoglobulins that are present, you're leaning towards C3 glomerulopathies. You can see that this is a very qualitative judgment call. So I don't want you to think that that's why it is true that in real life, sometimes we're trying to discriminate between an infection-associated GN, particularly when you didn't identify the infection preceding the glomerulonephritis, as can once again happen in 10% of cases. It's hard to make these conclusive judgment calls, okay? IgA present is fairly characteristic for Staph aureus-associated glomerulonephritis. So that's not uncommon. We've seen several cases of that. Staph aureus-induced glomerulonephritis with IgA dominance, okay? Again, sometimes all you see is C3 and making the distinction between C3GN and infection-associated GN is not so easy. Electron microscopy will show deposits in various compartments. Subendothelial and mesangial commonly will have deposits. The large subepithelial humps, as demonstrated in this electron photomicrograph, is another feature that leans one towards infection-associated glomerulonephritis. However, I'll highlight once again, this is not universal. That is, it's not necessary for the diagnosis, nor is it specific for the diagnosis, the presence of subepithelial humps. Management is typically supportive, meaning you treat the infection. The benefits of immunosuppression are really not proven in the literature. That being said, I think it is pragmatic that in some cases of rapidly progressive glomerulonephritis, it's really hard to do nothing. And so, you know, some practicing nephrologists will use immunosuppression concomitantly with the treatment of the infection when the patient is in, for instance, dialysis-dependent renal failure, right, or has a creatinine of 5. So immunosuppression can be considered. However, one has to keep in mind it is not proven beneficial in the literature. And, I can highlight several cases in which you treat an infection-associated GN with steroids at Parkland, and then they come back with sepsis in a subsequent admission. So I have to highlight once again, no evidence-based benefits of immunosuppression, and certainly there are harms, especially if you're a diabetic, right, and you've had infection-associated GN. Putting somebody on immunosuppression, steroid-induced immunosuppression, would have its obvious downsides. Okay,